So in the educational session at the EHA 2017, we had a session in the myeloproliferative neoplasms covering what the latest data with regard to molecular features of the disease. And Malali spoke about targeting JAK2 and what we know from a molecular and cellular perspective that might help us a bit better in terms of understanding how to better target that drug, how to better target that molecule and the JAK-STAT pathway. And then at the end, my job was to really look across the spectrum of the myeloproliferative neoplasms and look at what the emergent therapies were. So as we start with the more benign end of the spectrum, thinking about patients with PV and DT, I think the question still is open about interferon, about the interferon studies that were presented at ASH, MPDRC 112, with Pegasus versus hydroxyurea, and then in PV only, the Ro-Peg interferon alpha-2b or Peg-Invera, presented by Heinz Gislinger, looking at hydroxyurea versus that agent in PV. And the questions about still the equivalence of clinical outcomes so far, what is the long-term data, and then a pointer to the data that Jean-Jacques Kelagian will be presenting at this meeting about the molecular responses, because one of the surprises from the 112 study was that we were also seeing molecular responses with hydroxyurea. And what he's found in a cohort of French patients treated with Ro-Peg interferon alpha-2b is that actually the effect of the drug on the allele burden is in different aspects of the stem cell compartment. Then thinking about the role of ruxolitinib and other JAK inhibitors for these diseases, still reflecting on the fact that we need longer data for ruxolitinib in PV, and at this meeting we'll be presenting the 80-week follow-up from the response study showing ongoing clinical benefit and no new safety signals, which is of course very, very important for these patients. In the UK, I was able to share the unpublished data from our study in ET with ruxolitinib, looking at equivalent rates of controlling the blood count, and then also now 2 years worth of data, equivalent rates of thrombosis, hemorrhage and transformation separately, or when you look at them as a composite endpoint. Also thinking about how, in terms of emergent treatment strategies rather than therapies so much, how might we target these a bit better? So from our earlier studies in ET, we've been able to show that, for example, CALR positive ET patients treated with anagrelide might be more likely to get myelofibrosis, and conversely, JAK2 positive ET patients treated with hydroxyurea may be more likely to get venous thrombosis. So you can see how that might be then translated into clinical practice. If you've got a JAK2 positive patient who's got a history of venous thrombosis, maybe hydroxyurea isn't the drug to choose, etc. Then thinking about myelofibrosis, the emergent treatment strategies and the ongoing issues with how do we think about second-line therapy after ruxolitinib. And at this meeting, there'll be presented the phase 3 studies with momelotinib, some data of combining ruxolitinib, for example, with pomalidomide from the German group, and then thinking about what are our strategies for using other agents. So just highlighting that we're still awaiting data with imetelstat, PRM 151. In this meeting, there's a mouse model data presented with LSD1 as a potential target in myelofibrosis, which I think is really interesting. And then just a shout out for the rarer MPN patients, so the rarer diseases. So at this meeting, there's a poster presentation for patients with chromosome 8p11 rearrangement treated with an FGFR receptor inhibitor. So there was a single patient treated at the MD Anderson who had a really striking response. These are very sick patients. You can't cure them with anything except transplant if you can get them well enough to have a transplant. So there's a study ongoing with that. And then the interesting data with regard to systemic mastocytosis. So at this meeting, Andreas Reiter will be presenting data with regard to long-term follow-up with midostaurin, showing that it delivers a survival advantage for patients, and then flagging again that there's a specific inhibitor, BLU-285, that may be helpful for those patients. So that's kind of an overview of emergent therapeutic strategies in the field.